Hello friends, we would discuss about how to interpret a lipid profile report, a very commonly asked test in a cardiovascular practice. And we know that people who keep you happy still can develop a significant coronary artery disease. And this is another gentleman who is a comedian in India. That's what is happening in India. That means we are at a very high risk of developing a coronary artery disease in India, and there are regions in Europe based on European guidelines which are divided with Europe into four parts: low risk areas, and a moderate risk areas. We have a high risk areas and a very high risk areas. In Europe, we don't have enough data from India, but we know that India, this thing population falls in between this high risk and a very high risk categories, particularly the regions of Punjab, Kerala, and parts of West Bengal and areas around it, fall in a very high risk category. And so the calculation what we are going to tell you in future of score calculation would also depend upon which category of area you choose. If you are in India, then you choose a high risk category area. Why this? Because of the migration of human race from South Africa to various areas. They carried their gene along, and in between, when the genes had a newer transformations, then you had areas where there was a higher incidence of LPA, meaning a higher incidence of coronary artery disease as well. How do I get the lipid profile done? Should it be fasting by ritual? We are doing that, but I don't think so. That's necessary because the fasting cholesterol versus postprandial lipid profile shows that only triglycerides are increased by that marginally. Rest HDL and LDL, there is no difference. So it is convenient and good to get a non-fasting lipid profile. And let me tell you, most of the studies done for risk profiling and otherwise showed had a non-fasting lipid profile done in their entire study groups. How do I look at the lipid profile report? This is how I do it and suggest you guys do it, and I'll give you the reasons why I'm asking you to do the same manner. Now, LDL cholesterol is the first thing which I always look for. Then I look for a total cholesterol and an HDL cholesterol and calculate a non-HDL cholesterol. I may or may not look at triglycerides in case they are less than 500 milligram percent. So this is how I begin my journey of looking at a lipid profile report. So once you look at the lipid profile report, you just first look at the LDL cholesterol. Once you've done that, then you calculate a 10-year risk. There are many risk scoring systems, but I follow a score 2 system by European Society of Cardiology. You can download that free app, ESC risk, CVD risk is the app, and you can do it for your Android or a iOS phone. Once you've done calculated the risk and known LDL, then you find out risk modifiers. What are the risk modifiers? They are, let's say, non-HDL cholesterol is a risk modifier. It increases the risk. LP little a increases the risk. And then you have a clinical parameters like you have inflammatory disease, that you have a family history of a coronary artery disease, and these are the clinical modifiers of risk where you can upscale the risk from low to a moderate category and a moderate category to a high category. Coronary calcium score also is a risk modifier. So let me take you through this ESC guidelines to 2019, which was published in 2020. And this is the what are the high risk group of patients. High risk group of patients are those who already have a coronary vascular disease, either clinically myocardial infarction, ACS, or a CIBG, PCI, or subclinical when you get these on the test like a CT angio or a carotid Doppler. This is a documented atherosclerotic vascular disease. Second very high risk category is the diabetes plus another risk factor, be it hypertension, be it is family history of heart disease, or be it is smoking. So that puts you in a very high risk diabetes with the target organ, severe CKD, or you calculate the score, familial dyslipidemia with atherosclerotic vascular disease comes into a very high risk category. Now, the high risk category is there is increased elevation of LDL by more than 190. Then you have a patients with those who have familial dyslipidemia, and you have a diabetes without any target organ involvement or any other risk factor, moderate CKD. So this is the area. Then the moderate risk is as shown there. Low risk is the calculated risk of death, not a total cumulative risk, is less than 1%. Let us try to use this core 2 risk prediction algorithm. How was it developed? Very large number of patients or normal people were taken for, and there were more than 30,000 cardiovascular events. So very robust data what we have, but we applied this data in a prospective analysis also to see how does this scoring system works, and it worked well. And then they came out with these guidelines. What they say that you choose the sex, you estimate the 10-year risk of fatal and non-fatal CVD, and then you put in various European risk areas to calculate. For example, this the same. This is the group of male and female with this data, clinical data, and it depends which region are you living in. In case you are living in a very high risk area of the Europe, which I showed you, which is a part of the Russia, then Turkey, and then this is the risk if you are living in a very high risk area. If you are living in a low risk area, the risk is so it's a huge difference between the cardiovascular risk whether you are if you are staying in a particular zone. So zone where you are staying is very important. So this is the how we do it. You take the 10-year risk profile, you go to a score 2, that's what we like. In case the patient is diabetic, you can go to a diabetic score, or the patient already has suffered a coronary artery disease, you can go to this scoring system. We click on score 2 on Europe, and then we say which area are you living in. Being in India, we fall in a high risk category, so we choose a high risk region, and then we click next. And when then you are asked to give a systolic pressure, total cholesterol, and HDL cholesterol, choose the gender, choose the age, are you smoking or not, and based on that it calculates the risk of developing CVD, and this is the cumulative or a total risk what we calculating, not the fatal MIs, right? So now we calculate the absolute risk by using this score. Once we've done absolute risk, then let us find out the risk modifiers. So with an absolute risk, we can fall in a low risk category, borderline risk, intermediate risk, or a high risk category. In a borderline and intermediate risk category, it's a good idea to look for risk modifiers. Now, this being the largest category, now if we further add another risk modifier, for example, calcium score, and in case the calcium score is high, we would upgrade this intermediate risk into a high risk category. For example, if the non-HDL is high, then we would upgrade this intermediate category to high risk category. For example, in a borderline risk, if your calcium score is 0, we downgrade this risk of the person to a low risk category. So they actually change the risk category based on that. So we can reclassify the risk category. What do we mean by risk category and what is the clinical relevance? Now, if the person falls in a low risk category, the LDL cholesterol target is 116. In case it's the moderate risk category, then LDL cholesterol is 100, and in case the high risk category. So these are the tertiles of the targets of an LDL what we have based on a various risk categories. Now you calculate the LDL risk and then you calculate the risk modifiers. What does that mean? That risk modifiers, you can upscale the risk, or let us say go back to this and you have this risk category. In case the person falls in a moderate risk category and has a risk modifier, let's say the LPA is high, you come to a lower tertile. This becomes the target now. If a patient with a moderate risk category has a calcium score of 300, his risk from 100 goes to the target LDL goes to 70. So we are going to be more aggressive in this group of patients. What are the risk modifiers? Trying to explain in a bit of detail. Now you have a non-HDL cholesterol. You have a HDL cholesterol, which is total cholesterol minus an HDL cholesterol is the non-HDL cholesterol. And if you've taken this non-HDL cholesterol into your account, then you actually do not need a triglyceride calculation, because that does not really matter. What happens with this non-HDL cholesterol? They are mainly the triglyceride particles, and once the triglyceride increases, the dense LDL starts increasing. Now, small LDL is bad. So, higher the triglycerides, higher is the percentage of small del NCL. There is triglyceride levels where most of the LDL becomes small dense LDL. So, let's say these are the particles of LDL. You have the same 130 milligram of an LDL, and if you have a large LDL, there will be less number of molecules per 130 milligram. But in case you have a small dense LDL, you have a large number of particles. So same LDL cholesterol, you would have a higher number of LDL particles, meaning higher risk of atherosclerotic disease. More than that, small dense LDL goes and is more permeable and goes into the arterial wall easily. It is more adhesive. It calls phagocytosis more. It gets more oxidized and makes the unstable plaque vulnerable. Was a study on an unstable plaque histopathology showed 80% of the cholesterol in that unstable plaque was a small dense LDL. Let us talk about left LP little a. Do you have a genetic predisposition? It does not follow a Mendelian autosomal dominant or recessive mode. If you have one gene, we would have more increase in LDL, LP little a. If you have two genes, we are likely to have a still higher percentage of LPLA in our body. LP little a is a lipoprotein molecule which resembles an LDL, but there is a kringle of particle along with this is an this the look is exactly similar to plasminogen, and this is a kringle which produces a thrombogenic events. There is an oxy LDL here, the oxy lipids present. Oxylipids also are very highly atherogenic and produce atherogenicity. So if LPA is more than 50 according to European Society of Cardiology Guideline 2019, then it considered a high LPA. LPA has a more EC binding. It causes more smooth muscle proliferation. It causes more of the inviting more of the foam cells, and this kringle causes more inflammation. There is oxyPL there, and this oxPL also increases the risk of atherosclerosis and thrombosis. We now are developing some kind of drugs which would be effective in reducing LP little a. Currently, the statins tend to increase LP little a. the PCSK9 drugs, they tend to reduce LP little a slightly. So we don't have any drug to reduce LP little a as of now, but we are developing, we have a trial which would be published next year, and another 2 years we would have another trial to show whether it's effective or not. Let's wait for that. Now, the European guidelines say that anything more than 50 is abnormal, but they are gone to say that all adults, at least once in their lifetime, should be tested for LPA as a risk profiler. In case the risk modifier is present, it is present, then your LDL targets become different. So now, second aspect is that once you have LP little a, you should add an aspirin to that patient. And this trial very elegantly demonstrates the patient, those who have LPA, which is normal, the prevention of a cardiovascular risk and bleed is same. The incidence is same if you use aspirin. Okay, but in case the LPA is present, the bleeds are less, but the benefit is more. So in this category of patients, you can use aspirin along with the statin. Coronary calcium score, again the coronary calcium score, if it is 0, it's a good news. In case it's more than 300, it's very bad. Then it's very simple. It takes not more than 5 minutes to do it. No contrast is required. And let me tell you, this is a better risk profiler than TMT or a stress echo. The reason you are looking for an obstructive plaques in TMT and a stress echo and a nuclear stress test, but non-obstructive plaques are seen as the coronary calcium score. So we know that non-obstructive plaques are the plaques which are likely to produce cardiovascular event in more than 70% of the patients. So it's non-obstructive plaques which are important. Let's say if you have a calcium score of 300 plus, again, like an elevated LPA, we should add aspirin to this category of patient. There's a data available on that. So when to start cholesterol therapy? I mean, that's something very interesting. Should we wait for 6 months or 1 year for a lifestyle modification to tick in and then start cholesterol therapy? I have a different view. Now, this we have a new concept of cholesterol years. How many years the bad cholesterol high had been there in the body affects your outcome. For example, in familial hypercholesterolemia or a dyslipidemia, now the levels are achieved very early in age. You have cholesterol, high cholesterol number of years, and that is achieved early. Even if I have a mildly elevated cholesterol, after about 60 years, I have crossed this cholesterol years target or a margin and then become a high risk to develop a coronary artery disease. So this concept is important. Understandably, if I start statins or cholesterol lowering therapy early, I would prevent this cumulative cholesterol year period. I would buy more time in that format. And there is a study to prove that. And that study is that once we started PCSK9 inhibitors, and then there is a category of placebo group, and then there is a category of an active group. And at the end of the trial, placebo group also was given PCSK9 to reduce cholesterol, and their cholesterol reduced similar to the reduction with PCSK9 continued. So the similar result, one group of patients, those who had placebo and the other drug, and once you add this drug, the effect is same, but the effect is same. The difference is here. Those who were on placebo and then shifted to PCSK9, their risk was higher than those who were throughout. So that means this period of absence of PCSK9 made a difference in the mortality and morbidity, and that's why we want to say start the cholesterol therapy early. What are the challenges in statin therapy? Most of the challenges are that people are kind of oversensitized by social media that they would have some side effects. In fact, honestly, the side effect incidence is less than 10% it's overestimated and over diagnosed. And the areas to blame is the social media. Social media thrives on a controversy, and not taking cholesterol drug is a controversy, and this kind of circulates more frequently on the social media by the algorithm. So let's not go by the controversy. A lot of my patients come, they stop the drug, or they reduce the drug, or they take it infrequently. And this is the conveyed by the social media that cholesterol is bad. Second misconception they give is the dietary issue. Just control the diet. You don't need a statin. But that's not true. Diet only contributes to 10% reduction in cholesterol. You have a bad LDL receptor, you have a bad management of cholesterol in the body, and that's why it is high. So it needs drugs. Diet cannot control LDL receptors and other things. Okay, agreed. So now I have found a way. So I suggest them to use the chat GPT. So ChatGPT would give you an authentic data, would not enter into the controversial issues, right? So it gives you an authentic data. If patient wants to confirm whether we are right or the social media is right, then ask them to go to ChatGPT and it will give you an answer. Going to show you a couple of studies.